then of State Hillary Clinton. And is to significantly improve lives. Oops, sorry.
Tara, excuse me.
Yep.
I haven't shared your screen yet.
Okay. Give me a second. Remind me how to do that again, Shah.
Okay. On the main panel, there's share. And there's green button there.
Yes, great.
Thank you.
Yeah, of course. With me. Great. So I've already covered this one. So our mission is to significantly improve the health and lives of underserved mothers and babies in developing countries, finding and implementing mobile health programs alongside national governments and local partners. And vision is a world where no mother or baby in a developing country dies from a preventable death. So that I'm sure many of you who are health professionals aware of are that approximately 800 women die of preventable deaths each day during the maternal period, and 3 million babies die every year. And the majority of under 5 deaths in the first month of a baby's life. The opportunity that we leverage is that 1 billion women in low and middle income countries own mobile phones, and many more have access to mobile phones. I'll talk a little bit more about later. So the uses where we work is based on the challenge that I described, and opportunity. And so we have countries where maternal, newborn, and child health needs really intersect with the potential of mobile to address these needs. So this gives you kind of a snapshot of what that overlap or confluence of factors looks like. So these are the USAID 24 priority maternal child health countries, and the size of the bubble corresponds to the number of maternal and infant deaths annually, and color corresponds to mobile penetration, which is mobile phones per 100 people. The darker bubbles have higher mobile penetration, and the lighter bubbles have lower penetration. So we see when you look at this is that many countries stand out as having both high mobile penetration and high maternal and infant deaths. For example, India, you'll see Pakistan, Nigeria, Bangladesh, Indonesia sticks out, Kenya, there's a lot. And so I've identified on here which countries MAMA currently works in via our country programs, which I'll talk more about later. And then some countries that we work with through internet.org. And I'll talk a little bit more about internet.org later on as well. One of our founding partners, Space Center, MAMA developed evidence-based messages that are designed to inform and educate. And they're graded in a behavior change model, 2 models actually, that break down behaviors into actionable steps, ensure that a woman receives the right amount of information at the right time, and that the content is personalized. So the messages are timed and targeted. So when a new mother or pregnant woman signs up for the messages, they correspond either to where she is in her pregnancy, so with regards to fetal development, or the age of her baby if it's a new mother. And our core set of messages cover from 6 weeks of pregnancy, although most of the time women do not sign up for the messages that early, far from it, but they cover 6 weeks to the baby's first year of life. And you can see here a few examples of messages that a woman would receive throughout pregnancy, the baby's first year of life. I really offer a range of content that's designed to encourage women to take healthy behaviors, to go for care, but also help her identify warning signs, and they provide reminders of when to take certain behaviors. And there's kind of two domains of care that we focus on. One is in the home, so healthy behaviors the woman and her family can take on themselves in the home, such as nutrition, hand washing, exclusive breastfeeding, responsive parenting, all of those kinds of things. And the domain is the clinic. So, like I said before, explaining to women when they need to go for antenatal care, encouraging institutional delivery, and encouraging postnatal care, immunizations, checkups for the baby, all of those types of things. So we start with, like I said, that kind of core set of content and that core baby center approach. And for those of you that don't know Baby Center, they're really experts in how to talk to parents, in particular how to talk to mom. They have websites and apps all over the world. I'm not going to try and guess the number of countries because it's cool few, but they reach millions and millions of parents. So we have a foundation that Baby Center has worked with us to develop, and then for each country that we work in, we take that content through a localization and user testing process, ensure that it really aligns with local norms, that it addresses individual beliefs and practices in that country, it addresses stigma, so that it's highly local, highly relevant. And each country program has a slightly different process that they've gone through to develop content. But Baby Center has been involved in each location in this process as well. Beginning our country program discussion, we'll focus on South Africa. Our South Africa program is 2.5 years old, and it has reached over 1 million women. This program is really unique because, I don't know how many of you know, but there's a really high level kind of feature phones in South Africa. So we found that our target audience actually had access to, for example, web-enabled phones. So in addition to the MS channel, which is a text channel, so we're push text messages to men, and USSD, which is an interactive quiz type service. We also developed 2 mobile platforms that actually use data. So a B site, a mobile website, and we use Mixit, which is a social networking platform. And then one of the issues that we tried to address specifically in South Africa is, of course, the HIV burden. And the interesting things that we found was a really high preference among HIV positive pregnant and new mothers to USSD channel, and we suspect that this has to do with the fact that the messages are actually not saved on the woman's phone with that channel. So perhaps the sense of anonymity, and also a woman knowing that, if someone in her family was to come across her phone, those messages wouldn't be on there. So that's just something interesting to know. And the content in South Africa focused heavily on prevention of mother-to-child transmission. So I guess I probably should have said this before delving into the details, but in each country program, we work with a consortium of local partners to implement. So that consortium usually consists of a nonprofit partner, a technical partner, a clinical partner, and key public and private sector partners. So in South Africa, our prime implementing partners were Project Foundation, which is a tech foundation, and the University of Witwatersrand's Reproductive Health and HIV clinic. Together, those organizations worked to design the technical platform. They undertook the formative research that informed the content. And the University of Witwatersrand's Reproductive Health and HIV clinic, also known as WITS RHI, responsible for signing women up for SMS. interesting thing about South Africa is text messages were really, really expensive, and found that it was actually much more cost-effective to leverage some of those other channels I talked about, such as Mobi and Mixit, to women at scale rather than to try and reach women at scale through text messages. So there's actually a fixed number of women that we intended to sign up for text messages. Those women were all located in a part of Johannesburg called Hillbrow, which is where the clinic is. So the clinic workers at VITS signed women up for the text messages. So they were responsible for that component as well. In addition, Project and VITS have been responsible for M&E and research going forward, engaging with local and private partners. And those is a Vodacom partnership that they secured, which Vodacom agreed to zero rate the Mobi site for all users that have Vodafone as their operator. So that meant that, we were able to reach out more women at no cost, and we've seen that channel in South Africa has reached the greatest number of women so far. In addition, Vodacom agreed to sponsor the SMS service for 6,000 women, which was also amazing. Finally, I know it might be a little bit confusing. I've been talking about South Africa in past tense, and that's because the National Department of Health launched a nationwide pregnancy registry a year ago and leveraged the Mama South Africa work and partners, PRACEL and VITS RHI, to launch Mom Connect, which is a national maternal and newborn health messaging program that uses SMS, USSD, and they, I think, will be using some of the other channels as well. It has been amazing in many ways, but one of my favorite aspects of Mom Connect is they have a comments, complaints, and questions jar. They have a two-way messaging aspect to their program that allows women to send feedback on the quality of care that they receive. And that quality of care that the woman sends corresponds to a unique clinic identifying number. So it can be traced back to the clinic, which is all huge. The fact that they were able to assign numbers to every clinic in the country is impressive, to say the least. Our Bangladesh program is about 3 years old. We've reached a little over 1.4 million women and household decision makers. Our prime implementing partner in Bangladesh is Bangladeshi social enterprise, DINA. DINA has provided things in country, I think, but the most important was a lot of the formative research that they conducted. Really robust formative research that was qualitative and quantitative and spent pretty much the first year of implementation. And they learned a lot about both what women's mobile use looks like in the country, but also best ways to engage with the whole household. So one of the unique things about the Bangladesh program is that in addition to women being sent 2 messages a week, they send a separate message to a household decision maker, and that can either be a mother-in-law, a husband, or some other category. The idea there is that obviously there are, other people in the household that are making health-related decisions, and it's important to message them as well and to address their role in the care of the pregnant woman or the baby. And in addition, the Bangladesh program uses voice messages, interactive voice response, IVR, and that's due to the fact that many of our target women in country have really low literacy rates. So people can choose whether or not they want to receive text message or voice message, but the vast majority, I think it's over 2/3, receive voice messages. The other unique aspect of the Bangladesh program is that it's very heavily dependent on community health workers to sign women up for the content, or to receive the messages, rather. And a lot of that has to do with the fact that voice is a primary mode of communication there, and that women have low technical literacy as well as low literacy. So they need assistance in signing up for the service. So what DNET did was they partnered with 6 partners who are primarily NGOs, and each of those NGOs leverages their health workers or community agents who already have a presence in these communities, in every district in Bangladesh. These workers who already have gained kind of the trust and respect, know the community, to then go and sign women up for service and sign the household decision makers up with the service. One of the challenges had to do with the fact that when this program really took off and really scaled up, and we were working with lots and lots of community health workers through all of these partners, it became evident, and this is reflected in Bangladesh's formative research, that some of the health workers were not adequately trained on what the service was, so they weren't able to inform when they were signing up fully about what the service was and about the fact they actually were going to incur a fee, which leads me to my next point about this program. So Social Enterprise designed a sustainable business model whereby they charged a small fee to wealthiest, so that's lower middle income in this case, a small fee to 80% of subscribers. It's roughly 3 US cents a message. And they did extensive, like I said, when they did this research, one of the things they focused on was willingness to pay. So they found that they were actually willing to pay a small fee for the service, and that they found that the 80% of subscribers that did pay a fee would then subsidize the service for the 20% that were the poorest subscribers. But what we found when they did formative research was that many health workers were not aware of this model and thought that they could pay. So they're actually targeting women that they thought could pay, rather than seeking to, reach a wide range of women who would benefit from the service. And in addition, oftentimes the health workers who were given a small fee, the reward, the number of people that they signed up, the quality of the signups were not what we'd hoped for. So it the gambit from falsifying a user, so just registering a random phone number or registering people without their consent. So as soon as the DNET team had all of that information, they went back and met with these outreach organizations and did retraining of community health workers, but also changed the incentive scheme so that community health workers only received an incentive or a payment after a user had been signed up for service for 2 to 3 months, which let them see that these are real users, these weren't fake numbers, and that users actually were informed about the service. One of the things that the Bangladesh team learned in their formative research was that women really wanted to be able to talk to a doctor. So they added a 24-hour helpline component so that when women identify a warning sign or have follow-up questions, they can call this line and actually talk to a physician. And that's it. Let me think. I think the only other thing to note here is that, in South Africa, it means to partner with just one mobile network operator, which was Vodafone. In Bangladesh, our team was actually able to negotiate relationships and reverse billing with all 6 mobile network operators in country, which has been huge for this business model. Like I said, that they have reverse billing in place. And India is our newest country program. We launched in Mumbai 10 months ago, and the program there is called M-Mitra, which means friend in Hindi. We're just in Mumbai, in the slums of Mumbai right now, and are planning on moving to other urban slums in India, leveraging kind of the lessons learned and best practices from our work in Mumbai first. But the program there is run by an NGO called Arman, and a philanthropy called Dasra. And we've reached over 140,000 new mothers and pregnant women in just 10 months there. And this program also uses voice as the primary channel of communication, or most communication rather, with these women, given really low literacy rates. Nigeria is a country program that we hope to launch in November of this year. At the top, we have a lot of partners involved in Nigeria, including the SureP clinic system. SureP is the government of Nigeria's subsidy reinvestment employment program. And one of the ways that they reinvest subsidies is into improving maternal and child health outcomes through focusing on healthcare service delivery at the primary level. So we're working with SureP, with the Ministry of Health of Nigeria. Pathfinder International is our NGO partner. We brought on PreKelt based on the phenomenal work that they did for us in South Africa as our tech partner. Baby Center is involved in content development. And of course, Johnson & Johnson and US have provided funding. So if you remember I think it was the third slide that I showed with the bubbles, I'm sure many of you who are healthcare professionals know, Nigeria has the second largest global burden of maternal, newborn, and child deaths. And at the same time, the mobile penetration rate was pretty similar to what we'd seen in Bangladesh and India. Figured that once again, the confluence of these factors meant that mama could really achieve impact in this country. So stay tuned for more in Nigeria once we launch in the coming months. So that we noticed pretty on is that each country program has very similar goals and challenges, but has developed unique solutions to the challenges. So as I was speaking, I identified a few of these, and India's not on here, but definitely apply to India as well. For example, the content is different in each location based on literacy and the type of technology that women have access to. Technology platform is slightly different in each country program based on who our consortium of partners are. So, if we have PreKelt on board, it's going to look different than in Bangladesh, where our implementing partner, DNET, also is the technology platform. Like I said, the mobile network operator relationships are going to be different based on who the operators are in country, what their interests are, and also what our needs are. In a country like India, where there are tons of operators and none of them have a market share, it's better to know who to engage with. I think too, there are other players in the mobile ecosystem who you engage with as well. So it's something to keep in mind. And then again, kind of the sustainability piece looks a little bit different in these two countries. In Bangladesh, sustainability of the program has really hinged on this sustainable business model, the charging of user fees. DNET has also worked with local private sector companies, such as local pharmaceuticals, to sponsor the service. They've partnered with a seed company to advertise the service on the back of seed packets. We're constantly kind of pursuing new private sector angles as well. Africa, the sustainability of the program has really hinged on the National Department of Health kind of taking over the program. So do with these best practices, lessons learned, is we share them between country programs, with new country programs, and with what we call the mama community. Content, that core baby center content that I was talking about earlier, along with several other message sets that cover specific areas, are available on our website, open source. So we've seen over 300 organizations have downloaded the content, and we estimate that about 60 organizations in 25 countries are actually actively implementing the content or using it for research. Share what we've learned from our country programs with this community, and then in the vein, we take lessons learned and best practices from the organizations as well and share back with our country programs. That is something that we call global learning, circulating this information. Hosted a number of in-country workshops, but also created tools and resources that focus on some of these key areas, such as how to engage with a mobile network operator, how to pick the right technical platform, what does an ME framework look like for mobile health, for maternal born child health. All of these areas we've worked to build out tools and resources, and we've shared these with the individuals and organizations that make up the mama community. So this area of work that we've kind of branched out into is mobile broadband. So what we've seen is that mobile broadband penetration is increasing really rapidly at a rate that's 4 times in developing countries what it is in developed countries. By 2016, by some estimations, that 80% of broadband is expected to be mobile. So what that means in terms of projections is that many people's first and only access to the internet will be through a mobile device. So what we did to kind of learn this new channel is we partnered with Facebook for their Internet.org initiative, which is a Facebook-led initiative to bring connectivity to the 2/3 of the world that doesn't yet have access. And when I say connectivity, I'm talking about access to the internet. So free basic services and partner with them. So Facebook negotiates dating with a network operator in country, and that operator agrees to zero rate a platform suite of content rather. So, for example, Tigo in Colombia agreed to zero rate the Internet.org platform, which includes, weather information, sports, a few games, but also what they call core social impact content partners, which include UNICEF, Girl Effect, Nike Foundation, Malaria No More. There's a host of other impact partners who are on there. And so users that have Tigo in Colombia can access this content for free by going either to Facebook or going to the Internet.org page through their browser on their phone. And the idea is really that, we'll first internet users who otherwise wouldn't be able to afford data. And we'll be able to show them the benefits of the internet and show them that there's content in a local language, so it's relevant. And so the idea here is that this platform, it has a slightly different an audience, obviously, in our country programs, but that eventually, as mobile broadband becomes more ubiquitous among our target audience in these different countries, we'll have already kind of figured out what works in terms of behavior change communications on this platform. So we've been Internet.org for a year now, and along with our partner Baby Center, we've reached over 3 million families in 18 countries. So we've been able to reach a really broad geographic audience very quickly. But in country programs, we engage much more deeply with our users, and we have a much better idea too as to who they are and how we're impacting them. So impact. A lot of our research to date has really focused on So figuring out, how do we reach our target audience through technology that they already have? What type of technology does our target audience have? How do they use it? How literate are they? Using mobile devices? Can they send text messages? Can they listen to voice messages? What does literacy look like? What is the mobile, or what is the maternal newborn child health look like in countries? User testing, once we've actually developed the content and platform, to see whether or not users actually are satisfied with our content and our service. Do they test it? Would they share it with a friend? Do they stand it? Do they feel like it meets their needs? And then, that assessment is something that doesn't just take place the pilot or early stage, but something that is assessed routinely to ensure that, our platform is actually something that people value and that people understand and that's meeting their needs. So if we assess that, then we're able to, and once our program has been implemented years in a country, and once we have sufficient funding to do a more rigorous evaluation, then we've started to look at whether or not our programs are impacting knowledge, attitudes, behaviors, and practices. And finally, in countries where we have access to clinic records, can we tie those behavior and practices to health outcomes? So in India, we are just starting an outcome evaluation and a cost utility study. Like I said, that program launched last November, and we got IRB approval last spring. So they've been enrolling women in a randomized control trial, and they have, given that we use municipal hospitals to enroll women in the service, they actually have access to records. So we're able to look at key biomarkers such as hemoglobin levels, because anemia is a huge problem among pregnant women and new mothers in India, and they'll look at the baby's birth weight as well. And there is currently a dosage and exposure study underway, which will let, if women receive the service for a certain number of months, does the impact knowledge, behaviors, and practices. So if a woman receives a service for just 3 months, or 6 months versus 9 months, what does impact look like? But also, how does the quality in which she receives the service and she experiences the service impact those same indicators? So if she's listening to a message in full, it receives all of the content when she's supposed to. Those also, we would imagine, our hypothesis is they obviously impact some of those indicators, but that's what that study is looking at. And then the other study that the South Africa program is currently wrapping up is this comparison study, where they're looking at the different channels and whether or not one of the channels has a greater impact on knowledge, attitudes, and practices. And finally, in conjunction with Johns Hopkins and IWG, the CHI is doing a cost utility study. And finally, there is a huge external evaluation that was conducted by ICDDRB in Bangladesh that they ended up surveying, I think it was like 60,000 households to get the right sample size. And that evaluation also looks at knowledge, attitudes, behaviors, and practices among non-users and users of the service. It's not a randomized controlled trial. Actually, a lot of the quasi-experimental design, because this program has been nationally launched, and a lot of the marketing campaigns were kind of slum-wide or city-wide prior to the onset of this evaluation. So we can ensure that your group has had no exposure at all to the program there. But we expect that we'll be able to submit some abstracts from that research this fall, and hopefully some will be accepted, and we can share some of the findings later So that's it from me. I hope there are some questions, and so I'll turn it over to Cha for those.
For the comprehensive presentation, Tara. Here's some from our attendees. So the first one is, how were you able to engage the private sector in this initiative? What's it for them?
Great question. Yeah, so I think each private sector partner obviously is good in terms of how to engage them and what they get out of it. So, for example, when we've worked with operators in the country, one of the things that operators are interested in is obtaining new subscribers to their network, but also reducing churn. So ensuring that subscribers to their network remain customers. And in a lot of countries, there is a ton of churn. So a lot of people who are customers go to Claro and switch their SIM card like crazy. So one of the ways that we've pitched to these operators is they will help you reach a new demographic. A lot of these women are using their husband's phones, but one of the things we found in Bangladesh, where a lot of women are using their husband's phones, is really more women ended up purchasing their own phones after receiving the service and used mobile more. We also hypothesized they'll become more technically literate after using the program. So, like I said, we're going to be helping the operators gain access to a new demographic. Also, that will help them increase greater customer loyalty and reduce churn, because in addition to just being the network provider is somehow seen, like in the case of Vodacom in South Africa, as caring their well-being and sponsoring a valuable added service.
All right, Sarah, here's another question. How are you able to secure zero rates for local telcos in internet.org?
So I think that's not my job. That's Facebook's job. So Facebook is the one that negotiates with the operators. They deal exclusively with the operators in each country and do those negotiations behind closed doors, which they don't have to see through.
Hi, everyone. Can you tell me a little more about sending SMS HIV-positive mother in South Africa? Is there any data showing that this in RT adherence before and after the implementation of sending SMS to HIV pregnant women in PMTCT?
Yeah, excellent question. So, like I said, the PMTCT and ART adherence was a strong part of the content every channel in South Africa. So on SMS, USSD, the mobile website, and on Mixit. And part of that commission study, like I said, that's being done in South Africa, 5 bits RHI, look at the on knowledge, behaviors, attitudes, and practices with to PMTCT and ART adherence through. So that will be a component that standard of care comparison set that fits RHI is cropping up. So we'll have findings to share with everyone in the next couple of months. But yeah, that is a component to the research there.
Third question, is there any plan to conduct cost-efficiency analysis for evaluation in Bangladesh?
Yeah, the only country program that have that study underway yet. Like I said, there is a cost utility study underway in India and in South Africa. But Bangladesh, I think this very large external evaluation has kind of taken precedence. But I think it would be really, really interesting utility in Bangladesh, especially given, like I said, Dean's sustainable business model and the way they operate slightly differently than our other country programs. So it would be useful. No, we don't have one underway.
Another question is, how was first out, and where did the funding come from?
So MOM was launched in 2011 by then Secretary of State Hillary Clinton, and it was launched as our partners came together. So our founding partners are USAID, the UN Foundation, Johnson & Johnson, and Babysitter, and recognized, like I said before, that there is a confluence of these factors. You have high maternal newborn child health, maternal newborn mortality, and at the same time high mobile penetration. And there was a real need to drive demand for care, but also improve health practices in the household level. And so USAID and Johnson & Johnson made a $10 million commitment to MAMA for 3 years. So that's kind of how we started out and where the funding came from.
Right, question. When committee to give feedback, how large was their influence?
That's a really good question. So they have many opportunities. So in the formative research phase, one of the formative research that's conducted are focus group discussions. And after, like I said, after the content is developed and after the technology platform is developed, we do use testing to see whether or not, because one thing we found, this is interesting that we learned in Bangladesh. So women might say, in a focus group discussion, when you talk to them about, so one of the things that's important with voice messages is to make sure that you get the tone of voice that you are recording right, the person that's reading that message right, in the sense that respond well to who that person is and in terms of their authority to be providing this type of information. So in Bangladesh, women initially said they wanted to receive, well, it's different in urban and rural locations. So women initially said in rural locations that they liked this kind of dramatic role play format for content. I liked the familiar auntie to read the content. And that was during the formative research phase. Then 6 months later, when the team in Bangladesh conducted further research with users, with women, they actually said, you know what, we've received this service for 6 months, and we thought that we would like this format, but we actually find it strange to receive really serious messages, such as the warning signs messaging, dramatic role play format. So that example to say that at many different points in time, we engage our users and get their feedback in the service. So I think kind of the most significant point in time that we do that is during the formative stage. But for example, every month in Bangladesh, they do a phone survey of users to assess, like before, their satisfaction with the service, still willing to pay, if they trust the service, they think it's useful, and then if they have any additional feedback. For example, the call service was something that was not initially built into the program, but on receiving feedback from women that actually really wanted a two-way communication component, the DINA team in Bangladesh added that component to the program.
Tara, another question. After this 3-year funding from USAID, how are you able to sustain operations? Funding coming mostly from private or public sectors?
Excellent question. Yeah, so the commitment was initially for 3 years, and both USAID and Johnson & Johnson have supported us through 4 years now, which is amazing. But we are focused on bringing on new funders from the sector at this point in time to ensure that we're able to sustain operations in our existing country programs, but also that we're able to expand it to new countries. So we're currently pursuing funding. That I'll save off the hat. But at the country level, the consortium of partners in each country engages with local private sector. So, for example, in India, there are a lot of local philanthropies, private sector, that are interested in investing in a much type of program in their city or in their community. So our in-country teams are also exploring private sector angles. As before, I think sustainability also looks a little bit different in each country program. So in Bangladesh, the user fees have been a huge component of sustainability, and in Adina's ability to engage with, they've engaged with local sector pharma, supermarket chain, a seed company, all fund small aspects of the program there.
Tara, I also have a question. How did you first roll out this mobile? Around how much did it cost to start this program?
That's a question. I think that's part of like the cost utility study work that's being done. I'm not sure exactly how much it's cost in every country. Obviously, like I said, in some countries, messaging is more expensive than in others, which is why we tried to leverage other channels that are more cost effective. But then so I'm not exactly sure how much cost I can allocate to each initial implementation, but I can speak a little bit about where the heaviest initially and how those kind of shake out over time. So initially, the most expensive components are the formative research, designing the tech platform and getting the tech platform set up. It can be expensive initially if you don't have an agreement in place with an operator, or you haven't found a tech angle that's less expensive. The most expensive component, I think, is just the cost of sending messages out to lots and lots of women in some locations to their family members as well. So that actually, that cost can go down over time if you are able to, like I said before, either negotiate with an operator who will provide discount rates. If you can find a platform that's much expensive for when you're at scale. So in South Africa, the mobile website worked really well. Or if you're able to charge users a small fee, like in Bangladesh. But I'm not sure exactly how much each different program costs to implement.
I have another question. It's right for the mother. There are some who try for 3 months, for 6 months, 9 months. How often do these women get from you, and who sends the information updates to them?
Yeah, so women receive the service 2 times a week, SMS or voice in longer in South Africa through us, but through Mom Connect. In India 2 times a week, and in Bangladesh 2 times a week. But then in addition, in Bangladesh, there's that complimentary message, 1 per week, that goes to the household decision maker. It elects that. So not every single woman in Bangladesh will have those 3 total messages a week. If there's a household decision maker that is to get the message as well, then we send 1. And that the option is, it depends on when signs up for the service, but it can be long as from, the moment she realizes she's pregnant through the baby's first year of life, or, whenever in her pregnancy she registers, or whenever in the first year of the baby's life she registers. And the person or the organization sending content, so content is physically pushed out through our tech platform in each location. So in South Africa, Project Health Foundation now works with the National Department of Health to send content out. In Bangladesh, DNET has a tech platform that they've actually built in-house. So to send, actually built in-house with a of PrayCal. PrayCal actually went to Bangladesh and helped our team build a robust technical platform that could meet all the strains associated with reaching 1.4 million women and family members, but also the large variance in terms of types of messages that we're able to choose from. Like I said, urban versus rural women have different preferences, so they can choose what they want to read the messages, they can choose what time of day they want to receive the messages. There are a lot of options. So that tech platform required kind of a heavy rebuild, but capacity to handle all of that. So DNET sends out messages via their tech platform, and in India, Arman works with a technical platform that's not part of the organization, so they didn't have the technical capacity in-house, so they've actually found an external tech platform that they work closely with that sends the messages, and in Nigeria, it will be Project Health Foundation.
Thank you. Here's another question. Yeah. I think you can also see this. What is the biggest chunk of work, the most challenging part of each implementation?
Yeah, so I think the most challenging part of each implementation is, I think it's threefold, and I think these three factors are super interrelated, which is why I'm answering a question about the number one challenge with three things. And the three things are in the title of this webinar, and I think they're scale, sustainability, and impact. And achieving these three really interrelated things in each country program is super challenging because, we have to scale up nationally. But that's extremely expensive. So the sustainability piece comes into place. And in order to demonstrate impact, you have to, like I said, our country programs have been around 2.5 to 3 years, and we're just now able to conduct risk research that demonstrates impact because you have to be reaching a critical mass of users for a sustained period of time in a way that is super effective to even begin to assess impact. So, these challenges, like I said before, are similar in each country location, slightly different. So we've worked, like I said, really hard to tackle these issues in tandem, primarily in each location. So in South Africa, sustainability and impact have been through partnering with the National Department of Health, who's now taken over our program and engaged, I think it's over 20 other partners to achieve national scale, ensure that the program is sustainable, and also that it's impactful. In Bangladesh, I think once again, I said we've overcome this through partnerships, through partnering with DNET, who has in turn partnered with these 6 outreach organizations with presence in every single district in the country that ensures the scalability piece. Also, a lot of the formative research that they've conducted ensures that they're able to scale because they figured a way to correctly train these health workers and correctly incentivize them to ensure that it's reached. In terms of sustainability, same thing, partnerships in Bangladesh. DNET has been able at figuring out how to charge users a fee that they're willing to pay that will ensure the sustainability of the program over time, regardless of the number of women that they're reaching. And in vain, I think, once again, partnerships in Bangladesh have ensured impact because of the formative research they conducted, the routine M&E, like when asked how often do you talk to your users and get their feedback routinely, thanks to Dina. And then thanks to our partnership with ICDDRB, we're finally able to assess impact at a rigorous level. In India, same thing. Our partnership with Dada and Arman has meant that we've been able to scale in Mumbai to almost 200,000 women in less than a year. But there also, those two organizations are working very, very hard, like I said before, at the local level to engage local private sector organizations that are going to hopefully ensure the sustainability of that program. And then in addition, working very closely with reach partners in Mumbai to set up this CT to get approval early on and to be able to do the first RCT that we've done in a country program. So all of those three factors, scale, sustainability, and impact, are the greatest challenges, but I feel like they're so interrelated that it's almost one challenge. And I think we have overcome these challenges and are still working to overcome them through our partnerships across sectors in each country location.
For the answer, Sarah, follow from those three countries, were there other countries you initially engaged with and then eventually failed?
No, actually, no, there haven't been any others. Like I said, Nigeria is the next country that we plan to launch in. To work in other countries where we see that there's a need and an opportunity for our work. Also, the Mama community and the global learning work, like I said, have reached or have partnered with countries with firms that work in almost 30 countries. So we work directly in South Africa, Bangladesh, India, and Nigeria. We do broader geographic reach through our close work with the community members and through internet.org.
Next question for Denise. You think which one is to reach into the community actively? Mobile applications platform, social media, and text message?
So I think it depends on who you want to reach and what you want to reach them for. So in every single context, both in terms of like the location, your audience, and what the issue is. So there's some instances where mobile is not the best solution, right? I think there are many. Mobile isn't a silver letter for a single development issue. For example, there are super rural populations in countries that we work currently, and even in Nigeria, that still don't have or don't have network coverage. So that channel might not make them sense. Maybe it's radio. Maybe it's storytelling in women's groups. But then, for example, what we've seen through internet.org is then in India and the Philippines, your percentage of our target audience is going to have access to broadband or higher to web-enabled feature phones. Perhaps it makes sense to use a social media platform in those countries for us if we were to work there. It's really different in each location depending on what women have access to already, what they're comfortable using, and then once if you're making a behavior change for maternity, newborn, and child health, looking to do, someone mentioned antiretrovirals for HIV. That's a content area that's sensitive, so a social networking site makes sense, but you'd have to really consider anonymity, and privacy issues. So it depends on the subject and on the context.
Thank you so much for answering our questions, Tara. Spending your morning with us to share with Mama. Everyone for joining tonight's webinar. We remind you to answer the survey we'll be sending you in your emails, and may we invite everyone to join our upcoming webinars on September 24th and September 30th. Thank you, everyone. Thank you. Good morning.
Thank you. Good evening.
Good night, everyone.